Morning and happy April. Welcome to the 13th lecture in our series, Healthy Aging. My name is Steve Geringer, and I have the pleasure of moderating today's session. To start, I want to thank the Planning Committee and the programs that helped to make this possible. Those are the U of M Geriatric Department, Turner Senior Wellness Program, OLLI, Silver Club Memory Programs, the Turner African American Services Council, the Institute of Healthcare Policy and Innovation, and the National Poll on Aging. Today's topic is the phases and faces of dementia with Drs. Bruno Giordani and Judy Heidebrink. Before I introduce them in more detail, a few words about Zoom, which I suspect most of you are very familiar with at this point. The main thing to know is when it comes time to ask questions during the talks or afterwards, use the Q&A icon, which is typically at the bottom center of your screen. Just type it in and I will get the question. There is also a chat icon, which you can use to chat, but not for questions, please. Use the Q&A. Please note that we have a closed caption option for you to use if you want. On the Zoom screen, also typically at the bottom, will be the CC box. If you have any technical issues during this session, the easiest and usually successful thing to do is to leave and come back in. Leave the webinar and come back in. If you are still having trouble, call the Turner office at 734-998-9353. Now, those of you who have been watching some of the Healthy Aging series know that we have different topics by month. And this month, starting today, April 1st, is brain health. And today is about dementia, as I mentioned. Next week, same time, on Friday at 10 a.m., we'll be optimizing brain health during COVID-19, which should be quite interesting. Now, the usual disclaimer, the views expressed during the lecture and the Q&A do not necessarily reflect those of the University of Michigan. This format will be as typical. We will have the speakers followed by the Q&A. Now, it is a real pleasure to introduce our two speakers. Dr. Bruno Giordani is a tenured professor in the U of M departments of psychiatry, neurology, and psychology, and in the School of Nursing. He is the associate director of the Michigan Alzheimer's Disease Research Center. He's a past chair of the Michigan Alzheimer's Association, Great Lakes chapter, and was its national representative. He now serves on the board of the Michigan chapter of the Alzheimer's Association. Dr. Heidebrink is a clinical professor of neurology and the Richard D. and Catherine M. O'Connor Research Professor of Alzheimer's Disease at U of M. She directs the Neurology Cognitive Disorders Clinic and is co-leader of the Michigan Alzheimer's Disease Research Center Clinical Core. She has been involved in collaborative clinical trials in dementia for over 25 years, focusing on the diagnosis, prevention, and treatment of Alzheimer's disease. Now, those are just brief introductions, doesn't cover everything they do, so it's obvious they both have copious free time, and we very much appreciate their taking time out of their schedules today to make us smarter. Dr. Bruno Giordani, the floor is yours.
Great, thank you very much. So Judy's putting up the slides. We know that Judy is much better at shifting slides than Bruno is because inevitably I go the wrong way or something, but today we're meeting to talk about the phases and faces of dementia. So really excited to be here and we appreciate it. Judy goes, next slide. We're going to talk about basically an outline of what we're going to talk about today. talking about the dementia, some dementia basics. So we all understand that. How you diagnose dementia, histories, exams, and testing. Judy's going to talk about that, and common causes of dementia that Judy will go over with you all, including some vignettes. And then we'll talk a little bit about treatment, talk about medications that work, and even some things that we can all do that are what they call non-pharmacological types of treatment, non-medication treatments. Next slide. Now, what exactly are we looking for when we say dementia? What are the sort of common symptoms? And we know these things include difficulties with everyday tasks, confusion in familiar environments. Sometimes people have difficulty putting words together, and we've seen that recently, actually, with one of our movie stars, and memory loss and changes in mood and behavior. These are all potential signs, but the most important, or one of the most important components in this, is that we can say this is a decline from how people usually used to be. So yes, there's been a decline from a previous level. And most important, that this impacts daily functioning, that the person can't continue to work as they used to or to act as they used to because of these cognitive difficulties. And again, of course, it means in an awake, alert individual, not somebody who is delirious that really, because of some medication problem or other issue, doesn't quite know where they are. Next slide. So often I'm often asked, just sort of, well, what's normal and what's not normal? So I just put up a slide, and you all can see the slides later, just about some different things. So that, for example, it's not just forgetting a name, because we all forget names. I am the worst person with names, but it's not recognizing a family member. That's a big difference. Or it's not losing your keys or your glasses. We all misplace things because we're in a hurry and busy sometimes. Actually, I now have those little clips on my keys that alert me, that tell me where they are if I can't find them. But it's something not like losing your keys that we all do, but let's say putting your iron in the freezer. So it's not just gradual changes that sometimes we all see in ourselves because of attentional changes and mild things that happen with aging, but it's a sudden dramatic change, personality change, a cognitive change. Next slide. So how do we diagnose dementia? So the first way, in terms of diagnosing dementia, first we're looking for a decline in thinking. And we look at some classic measures like memory loss, language difficulties, trouble with spatial perception and understanding, or problems with sort of common day reasoning, like keeping yourself organized. It's a change in function. And a change in function when we rule out other conditions and we don't know what, we can't figure out what's going on, but people who have difficulty organizing, people who can't do common things they've always done, like get their groceries at the grocery store. Our center has a large study ongoing that we're always looking for people to participate in, for example, that involves early indicators we may see when you're driving. So healthy individuals, when they're driving, do they begin to make little mistakes that become more consistent? Next slide. Sometimes you'll be asked to do neuropsychological testing. And that really looks specifically at these skills like memory and reasoning. Like memory, it says, remember these words, you might be asked. Reasoning, you might be asked, how are a banana and an orange alike? What's your reasoning like? Language, what is the name of this thing? What is this down at the bottom right? What's that called? Is that called a clock? What your language, your knowledge of words and understanding. Could be spatial perception. What time is it? Where do you know really where you are time-wise and localized? And it could be planning. So for example, you may be asked to draw a clock. It could be, when we plan out the numbers, we may have real trouble figuring out what the order of the numbers are. And it's also looking at, neuropsychological testing is also looking at mood and behavior to rule out things that may cause significant difficulties, such as a a significant depression or not. Next slide. So I want to note this important that dementia is common and it's growing. If you look across the Americas, if you look in Europe, Asia especially, it's growing. I can tell you that I do a lot of work in Africa, and the expectation now is that these numbers are very different and actually increasing even more because so many people are living to a longer age because of changes in how things are organized, in cleanliness, in HIV interventions and things. But already we know based on now that if you look at over 46 million people in 2015, by 2050, we'll have 131 million people. Think about that number is just huge. Next slide. And I will tell you one of the things that's most distressing, if you look at the increase in these numbers coming along, if you look at that sort of reddish color there at the top, it's really the low and middle income countries that will have the biggest increases. This is where things become, in particular, very significant, so that we're going to have to really attend to the problems in those areas. Next slide. Why is this happening? Well, one of the reasons is that dementia rises with age. The risk of dementia increases. As a matter of fact, your age is considered your highest risk factor. With people over 85, there's often a 40 even or more % chance of having dementia. So it increases with age. Next slide. And the other thing is people are living longer. That's the first thing. We all are living longer now because of healthcare and other things. And more importantly, it's the fault of people like me who are baby boomers, let's say. So if you look at baby boomers on that slide who are turning 65 on that sort of middle column, those are much higher numbers as they move forward. So more and more people are going to get older across the world because of the baby boomer generation. It's just more children were born back in the 50s, and now we're seeing that big increase playing out. Next slide. So one of the questions is dementia preventable? What are some of the risk factors? Now, I've already mentioned age. We know genetics plays a small part too. Next pictures. But one of the things is there's also been a lot of work done, and most recently, a year or two back, there was a big article in the Lancet about the fact that 40% of dementia cases probably could be prevented by addressing lifestyle issues. So we know that a lot of these different lifestyle, and in that paper from the Lancet, they actually figured out roughly when the best effect to make these changes are. For example, early life, we know that people who have better education seem to be more protected from risk, probably because they have more in there to lose and to be protected. Very interestingly enough, and much to the surprise of a lot of people, hearing loss actually contributes quite a bit to this risk. And that was a really surprise that people found, but there are a lot of other things that can happen. Smoking is a big one. Even depression and social isolation, the idea that you're socially isolated and essentially not using your mind makes a significant difference, as well as other things later in life, especially like air pollution, diabetes, and heart disease. Next slide. So, we at our center, we're doing quite a bit of work looking at the interaction between hearing loss and the appearance of dementia. But from the research that has been going on, it's very clear that wearing hearing aids really reduces the risk of cognitive decline. Now, part of this is probably that people are more socially isolated when they can't hear well, but it's really appears to be an interesting factor about the interactions. People, if you talk less, you get involved, but The most important thing to think about is 90 to 95% of people with hearing loss can be treated with hearing aids. So it's by either hearing aids or cochlear transplant. These are big, important research areas to consider. That how can we intervene? Next slide. I just wanted to mention smoking because it's sort of an example of those complex reactions that occur. So smoking is one of the bigger lifestyle risks for dementia, but it's through this interaction where people who smoke heavily increase their risk of cardiovascular disease. You get changes in the blood vessels in the body. Diabetes, stroke often happens. And there's even a suggestion that intaking smoke causes changes which really can damage the brain directly. So that's an example of sort of one of the risk factors and how it's a whole interplay. Next slide. So we'll talk a little bit later about other things that are helpful, but there are just basic ways that in which to protect against dementia. The Alzheimer's Association is sort of coordinating all of the, they call them finger and pointer studies, all of these now ongoing studies across the world, looking at ways we might protect ourselves from dementia. Keeping cognitively stimulated, keeping active, keeping socially engaged, meeting with friends and volunteering, essentially using your brain rather than losing it. So all these activities we do as older, people who come to this talk, all of these things are important. Now we're going to switch over to Judy.
All right, good morning. I just want to do a quick check to make sure everyone can hear me okay. As we've already heard, we know dementia is common and growing, even though there are some exciting things that we may be able to do to prevent the development of dementia, because age remains the #1 risk factor and we haven't been able to solve the problem of getting older. Unfortunately, we're going to continue to see individuals with dementia for the foreseeable future. And besides determining whether someone has dementia, it's also important to determine why they have dementia, because not every cause of dementia is the same. So what are the causes of dementia? Well, if we were doing this talk about 200 years ago, first of all, we wouldn't be doing it through Zoom. We wouldn't even be on the telephone, I don't believe. I think someone would be madly typing on a telegraph somewhere. But if you look at the medical textbooks back in the 1830s, here's what they listed as causes of dementia, or what they were calling sort of maladies of the mind at the time. And some of these on the left, we would still consider potential causes of dementia. Again, they recognized even then that age was at least a risk factor for dementia, but excess alcohol is still thought of as a cause of dementia, head injury certainly. Some of the factors listed on the right, though, maybe indirectly in terms of depression potentially playing a role in the risk of dementia, but others we don't really think of as current causes of dementia. So what is our current list of causes of dementia? Well, the list is quite long, but only a few causes of dementia really stand out as being the most common causes of dementia. And by and large, as a group, the most common causes of dementia are the neurodegenerative disorders. So these are disorders where it's a primary problem of the brain function. The nerve cells are being injured and losing their function or dying out at an accelerated age because of some intrinsic abnormality going on within the brain itself. And of the neurodegenerative dementias, Alzheimer's disease really dominates in terms of being the most common cause of dementia. It accounts anywhere from probably half to 2/3 or more of dementia in individuals past age 65. And because it is so frequent, sometimes Alzheimer's dementia just becomes dementia when spoken casually, but there are definitely other causes of dementia that are not Alzheimer's disease. And those include Lewy body dementia, frontotemporal dementia under the neurodegenerative category. There's also a sizable percentage of dementia due to vascular disease, and then sort of everything else, including some of the things that might potentially be reversible if identified and treated. Unfortunately, those reversible dementias only make up a small percentage of all of the causes of dementia. And you can see these estimates, will vary a little bit depending on where you look them up. And they also don't really account for the fact that in many cases, there are multiple causes of dementia within the same individual. So so-called mixed dementias, where someone might have Alzheimer's and vascular disease, or Lewy body and Alzheimer's changes. Those are quite common too. So these numbers are going to add up to more than 100%. So how do we decide what the cause of dementia is in a given individual? Well, it's similar to other tasks that we do as a clinician, and that is we take a good history from the person and those who know the individual experiencing the changes, an examination, and besides tests specifically of their memory and thinking, we'll also do a series of routine tests to at least rule out easily reversible causes of cognitive impairment. So our history, we're going to ask about how long have the symptoms been going on? Did they sneak in gradually, or was it a very sudden or abrupt overnight type of change? Have the thinking difficulties continued to progress over time, or have they been relatively stable after starting rather suddenly, as you might expect with something like a stroke? Has there been a known stroke or a head injury that seems coincident with the beginning of the symptoms? And what are the most prominent symptoms? Is it memory loss? Is it trouble finding words? Is it trouble with reasoning? Is it trouble making sense of what one sees? Or is it a lot of mood or personality changes? Because the different types of dementia are characterized by a different combination of cognitive symptoms and behavioral symptoms. Are there any medications that could be contributing to the cognitive impairment, or a history of substance abuse? And what's running in the family? Some of these dementias have a stronger genetic risk factor or family history than others. So knowing what's running in the family can help us determine the diagnosis for an individual. In addition to doing the cognitive testing that Dr. Giordani already spoke about, we're going to look at the rest of the neurologic exam and see, are there any problems with a particular type of task, what we call focal findings, where maybe someone struggles using the left side of their body compared to the right, which might tell us about a process in a particular location in the brain, usually on the opposite side, the way the brain is sort of cross-wired with the body. Is the individual having any trouble walking or gait changes that can be a sign of certain types of dementia? And specifically, do they show any signs of Parkinson's disease or related Parkinsonian conditions like tremor, stooped or shuffling gait, things that can be a sign of a Parkinsonian dementia. And then the right hand of the slide just lists the standard lab tests that we would do routinely in anybody coming in with significant cognitive changes. And typically a careful brain image like a CAT scan or an MRI is done as well. So if we put all this together, how do we decide what the cause or face of dementia this person has? So I'm going to focus on the 4 most common types of dementia shown here. Some of you may already be familiar with the typical signs of symptoms of one or more of these causes of dementia based on knowing someone who's experiencing one of these types of dementia. And some of you may also know some of the famous faces of dementia, famous individuals who have been diagnosed as having or had one of these types of dementia as well. So what I'm going to do next is just kind of describe what a typical scenario would be for an individual's experience each of these types of dementia, just to help us understand what is the appearance or the face of each of these types of dementia. So we'll start with this first case description, and these are all hypothetical. They're not actual cases, but they're just generated to sort of demonstrate the most typical features of a given condition. This is a 76-year-old woman, and she's been experiencing a gradual decline in her thinking for the past 2 years. So it didn't start overnight. It's been kind of creeping in, hard to pin down exactly when it began, but it looks like it's progressing. In particular, she's forgetting recent events. She may remember things from years past more easily than things she did a few days ago. As a result, she will repeat a question or repeat a story, and she's needing reminders for things that are time and memory dependent, like did I take my medications or what's on my schedule for today? And she might also pause to think of words, but if someone supplies the word she was looking for, she'll recognize it. So it's not as though she's lost her understanding of words, it just is taking her more time to access those words. And otherwise, she's in good physical health. There aren't any concerns about things like head injuries, no symptoms of depression, no sleep problems, and no history of excess alcohol or a stroke. And on her exam, if you're asking her what day is it today, she's a little bit off. She thinks, well, we had St. Patrick's Day recently. It maybe is a day or two after that. If you test her memory, ask her to repeat some words and remember them a short period of time. She has trouble recalling those words later. And she's able to name objects like a pen and a watch, but if you start asking her to name the parts of the pen or the watch, she calls the watch band a wrist holder. So kind of describes its purpose, but not the exact name for it. But the remainder of her examination, her physical examination, she doesn't show any, quote, focal findings, any Parkinson's features, any walking difficulties. And if you do the standard laboratory and imaging evaluation and obtain a brain MRI, there isn't anything dramatic, no stroke, no tumor, but you might see atrophy or brain shrinkage, which does happen in all of us, starting probably around our 30s. But in her case, it looks like it's a little accelerated for her age. Now, that's always a bit of a judgment call since the brain shrinkage does increase as we get older. But here are just two representative portions of an MRI scan focusing on what's called the temporal lobe of the brain. So it's as though the individual is facing us and the MRI images are flipped left to right. So this is actually the individual's left temporal lobe as they're looking at us and their right temporal lobe. And there's a structure right here called the hippocampus, which is named that because it resembles a seahorse because of its kind of curvature. And it's an important memory structure, particularly for trying to get new memories to stick, so to speak. And in this case, the MRI, the hippocampus kind of takes up all the room that it's allotted. It looks normal volume, whereas in this individual, the hippocampus has atrophied or shrunken down. So there's this extra space around it on both sides. You can also just see the temporal lobe in general. There's this extra dark area or space. So there's what looks like accelerated atrophy for this individual, and particularly in centers that are important for cognitive tasks. So suggesting that something is going on potentially microscopically or under the surface that the MRI can't tell us fully, but it's giving us sort of secondhand information that something is accelerating that atrophy. So this individual has some of the typical signs and symptoms of Alzheimer's dementia, again, the most common cause of dementia. Symptoms often begin after age 65, though there are clearly exceptions to that. The beginning is gradual and the progression is gradual. So if someone says their dementia began on an exact date, I would be very cautious about making a diagnosis of Alzheimer's dementia. And typically memory loss, particularly for short-term memories, is an early feature and often the most prominent type of cognitive change. And the non-cognitive parts of the brain function, so strength, feeling, coordination, vision, things like that are not typically affected, at least for quite some time. And imaging, other than showing perhaps some accelerated shrinkage or atrophy, doesn't show any structural problems like a stroke, tumor, things like that. In the past, we would say that to ultimately know, does an individual definitely have Alzheimer's dementia, we would have to wait until they passed away and perhaps donated their brain to research and examine the brain microscopically to look for the hallmark pathologic changes in the brain, the amyloid plaques and the tau tangles. It turns out we can actually visualize, so to speak, the accumulation of those plaques and tangles in living individuals using more specialized brain scans called PET scans that involve tracers that are given intravenously and can bind to the plaque if it's there or the tangles if they're there. And by labeling these tracers with a small amount of radioactivity, a PET scanner can pick up where the binding is occurring and determine if there are high levels of binding or just minimal, quote, normal levels of binding of the tracer to determine whether an individual really has the hallmark findings of Alzheimer's, the plaques and tangles. So on the right-hand slide, these are just representative PET scans. The first two images on the left are from someone who is cognitively normal, CN for cognitively normal. And if they're given a tracer called PIB that binds to the amyloid plaque or the A beta, the beta amyloid, the binding levels are relatively low. So the blue color would be a low level of binding. And similarly, if they are given a tau tracer, very minimal levels of binding as compared to the individual who's clinically felt to have Alzheimer's dementia, the bright red, pink colors are designating high levels of binding. So there's really a lot of evidence of amyloid plaque kind of throughout the surface of the brain, the cortex or thinking parts of the brain, and tau as well, depositing, particularly in these temporal lobes. This is the same area that I showed you previously on the MRI. Again, a major memory center for the brain. So in this case, we would have really supportive biological evidence that this individual was experiencing Alzheimer's dementia. But unfortunately, these PET scans are not routinely available in the clinic. The tracers are they're proprietary, they're expensive, they decay, their radioactivity decays, so they have to be shipped from their manufacturing center, so they may not be available geographically in many places, and they're quite expensive, and at the current time, there isn't insurance coverage for the PET images, but Medicare is doing some studies to consider whether that might change in the future, so we'll have to stay tuned. But one other exciting development is that you can also measure levels of the proteins, the amyloid protein and the tau protein. Oops, you can measure it in spinal fluid and get some indication of whether those proteins are accumulating in the brain, but that involves an invasive test, a lumbar puncture. But more excitingly, it looks like we can start to measure those same proteins more accurately in the blood. And so there's been a lot of development in the last several years of potential blood biomarkers for Alzheimer's disease that may make their way into the clinic in the near future. One is actually commercially available, although its accuracy, unfortunately, is not 100%, but I think there may be some better blood biomarker opportunities coming in the not too distant future. So the description that I gave you of the hypothetical 76-year-old woman, she would be considered as having mild Alzheimer's dementia based on the types of things that she is struggling with. Alzheimer's dementia does progress over time and can be divided into phases or stages, roughly speaking, mild, moderate, and severe. So the milder stage is characterized by those short-term memory symptoms, so forgetting recent events, paying bills, things like that. Speech can be more vague, a little bit of trouble finding words, and people can have troubles just initiating or organizing tasks. As it advances to a more moderate level of dementia due to Alzheimer's, people can have more trouble with orientation and needing more, starting to need assistance with more personal tasks like dressing or using routine equipment or appliances, things like that. And then in its latest stages, usually many, many years after the beginning of the symptoms, that's when long-term memories, very familiar places, and people start to become lost, and speech may be very challenging, and you can develop some late-stage physical complications like incontinence, for example. The symptoms themselves, in terms of what is causing the symptoms, they actually correlate more with where the tau is accumulating in the brain compared to where the amyloid is accumulating in the brain. And so here on the top of the slide are just two more tau PET scans, now showing you the left side of the brain and the right side of the brain as a side view. So the temporal lobes are now here. And early on, again, there's a lot of tau in the temporal lobes where short-term memory and some aspects of language reside. And over time, you may see more tau involvement in the parietal lobes and then later on in the frontal lobes. But where you don't see it are in the basic parts of the brain that coordinate things like movement and feeling. So the physical aspects of the brain are spared by those tau accumulations, which is why, again, Alzheimer's is relatively isolated as a cognitive impairment and not a physical impairment. All right, let's move to another case with a different type of dementia. In this case, it's a 66-year-old gentleman. He had a known stroke 6 months ago that affected the right side of his body. He developed weakness and difficulty speaking, which would suggest he probably had a stroke on the left side of his brain, because most people, language abilities reside on the left side of the brain, and with the cross wiring, that's why he has the right-sided weakness. He was improving from this kind of gradually, but then he became suddenly confused and started bumping into walls. And when he was eating, he would look at the food on the plate, but would just miss it, only eat portions of the food and kind of not see or be aware of food on parts of the plate. And on his exam, he still has some difficulty producing words, but also has trouble with spatial tasks, like looking at an imaginary clock, maybe one that doesn't have any numbers on it. Can he tell that that looks like 9:30, or in his mind, is it sort of flipped and he might say 3:30? He's still weak on his right side and has a blind spot in his vision. He has trouble seeing things off to the left. So in contrast to the previous case, this individual has problems with the physical aspects of brain function. And his MRI shows multiple areas of strokes. Again, the brain images are flipped left to right. So this is the left front of his brain showing that previous stroke, but also has one now on the right side of his brain in the parietal temporal lobe. So and kind of all these are important areas of the brain for thinking, but they also control physical functions as well, leading to him having these blind spots in his vision and the weakness as well. So this would be a prototypical case of an individual with vascular dementia, which as a sole cause of dementia may not be terribly common, maybe less than 10% in dementia autopsies, although those may be a biased number based on who has a postmortem brain evaluation. But at least some degree of vascular changes are felt likely to contribute to dementia in up to 40% of cases. So it's often mixed with Alzheimer's dementia. If someone has Alzheimer's, or excuse me, vascular dementia, there can be a variety of ways their symptoms can begin or progress. In the example I just showed you was the multiple infarctions that begin suddenly and in a stepwise fashion. So the individual can do fine, and then suddenly they decline if they have one stroke, and then they can plateau for a while, then a sudden decline again as they have another stroke. And so when you examine them, just depending on where those strokes occur, they may have a lot of trouble with one type of thinking, maybe word finding, but their memory might be fine because the stroke didn't affect the memory centers. And again, in contrast to Alzheimer's dementia, they can have physical impairments, not just the cognitive impairments. Another type of vascular dementia has a more gradual onset and progression, and this can be the accumulation of these sort of deeper changes down in what's called the white matter of the brain, kind of ringing the area of the fluid pockets, the ventricles of the brain. And so when people develop microvascular changes, this may not cause any type of sudden confusion, but it may be a more gradual process where their speed of processing information or their reasoning just are slower and less accurate. So it can be hard sometimes to distinguish that from Alzheimer's, although again, memory may be relatively spared in this individual. And so to really make a diagnosis of vascular dementia, the clinician is trying to correlate what are we finding on exam, whether it's a certain pattern of thinking changes or a certain type of physical changes, and is there evidence of vascular disease on brain imaging, for example, that explains those findings or not. And the course can be variable, again, because someone who might have a stroke may never have a future stroke, and so they may have a relatively static course or improve over time rather than inevitably progressive the way Alzheimer's dementia progresses over time. All right, I'm going to switch now to a third case. This is a 68-year-old gentleman. He is referred for memory loss, which is probably the most common thing we see on referrals to our clinic. But when you start talking with him and his wife, they don't really describe problems with memory. He's not forgetting recent events. He's not repeating himself. He has more trouble with decision making, like getting to a complex intersection, which lane goes which way, where do I need to be if I want to make a right turn or a left turn. Some days he's just a lot more confused, almost sort of staring off like he's daydreaming. And he has trouble on those days in particular, he may have trouble recognizing his wife. So, what would we think of as a sort of a long-term ability or long-term memory. And he's also made comments about seeing cats in the house, which is fine, except they don't own any cats in the house. So it seems though he's developed some hallucinations of these cats being in the house. And he's also experiencing some physical changes. His walking is becoming slower. His balance seems off. And interestingly, he has a very long history of what his wife described as being an active sleeper. And by that, she means that once he's asleep, when he seems to be heading into a dream, he is physically carrying out the actions of whatever is happening in his dream. So if he's marching in a parade, he's pumping his arms and moving his legs. And so she's learned to kind of get out of the way or avoid getting, hit, kicked, or punched by depending on what he's dreaming at night. And that's been true for many, many years before these thinking difficulties began. And when you examine him, he's somewhat slow to answer, but he's still able to accurately tell you the date and remember a list of words as well. So it's not really a memory problem, but he has more trouble with things like visual spatial tasks. So this is an example of someone trying to copy two pentagons that overlap, and it turns out they drew mostly a pentagon with sort of an overlapping triangle and then a few other lines and swirls along the way. So trouble with those visual spatial tasks. And on his exam, he is walking at a slower pace with a stoop and a bit of a shuffle as well. And his brain MRI does not show significant atrophy, again, in contrast to the first case with Alzheimer's dementia. So this person is exhibiting some of the hallmark symptoms of what's called dementia with Lewy bodies, which is named for its type of protein deposit in the brain in the form of a Lewy body, which is depicted here, which has a primary protein called alpha-synuclein. These Lewy bodies were first described in the brains of individuals with Parkinson's disease, where the Lewy bodies were found in the motor pathways of the brain, but these Lewy bodies can also accumulate in nerve cells in the thinking parts of the brain and be associated with a dementia. The age of onset is similar to the age of onset of Alzheimer's dementia, but dementia with Lewy bodies is more common in men, whereas Alzheimer's dementia is more common in women. And besides having a dementia, the hallmark features of dementia with Lewy bodies can be some of the non-cognitive symptoms, some of the physical symptoms like Parkinson's type symptoms, some of the psychiatric symptoms, in particular, very vivid and recurrent hallucinations, and this interesting ability to enact one's dreams, whereas in most cases, when we're in the dreaming stage of sleep, our muscles are in a state of paralysis other than we continue to breathe and we have the rapid eye movements that characterize dream sleep, the REM sleep. But individuals with dementia with Lewy bodies lack that paralysis during the dream stages and can physically act out their dreams. And this is often something they've been doing years before the onset of the dementia. So it may be a sign of Lewy bodies accumulating in a much earlier stage in the parts of the nervous system that control dream and sleep habits. And there's also an interesting, besides this being a progressive dementia, there can be pretty dramatic fluctuations, not linked to any illness or medication change, but just periods of time for sometimes hours, sometimes days or more, where the person is just much more confused, maybe even kind of staring off or daydreaming, and then they may recover and seem much sharper on other days. And unfortunately, we don't have PET scans that can see these Lewy bodies, so we don't yet have the potential to really look into the brain and know with certainty whether an individual is accumulating Lewy bodies, but there's a lot of work on biomarkers for Lewy body, for dementia with Lewy bodies as well, and including some recent reports that you might be able to pick up synuclein deposits, the protein that is in the Lewy bodies, in places outside the brain, like in nerve cells in the skin, for example, is being looked at. So the dementia in dementia with Lewy bodies is a little bit different than what you might see with the typical case of Alzheimer's dementia. There's more problems with attention and problem solving. So if you ask an individual to do something like look at a series of letters and make a slash or hash through each E, just being able to get through this quickly and accurately, someone with dementia with Lewy bodies will likely struggle more than someone with Alzheimer's dementia. As I mentioned before, visual spatial impairment, so copying tasks can be difficult, but it's not just a motor. You might argue, well, if they've got Parkinson's features, maybe it's harder for them to draw, the tremor interferes, but just making visual spatial judgments, like if you look at this angle, which one is a match of the choices below, that can be more difficult. Whereas their memory may be relatively preserved and their language skills as well. And dementia with Lewy bodies is really more than just a dementia. There are many other aspects to the condition, including the physical aspects. Many cases, you'll see aspects of Parkinson's-like features, slower movement, reduced balance. Psychiatric features are very prominent, including the hallucinations that I mentioned previously, but also there's interesting phenomena where people will think things have been taken or replaced by imposter versions of themselves. So someone might think their spouse has been replaced by a very similar but not quite identical spouse, just like this series of, quote, penguins. One of them just doesn't quite look like a penguin anymore. Or someone's home may not be recognizable. This looks like my home, but who replaced it with this identical version of it? Anxiety and depression can often occur with dementia with Lewy bodies. And then various sleep disturbances, not just the dream enactment, but sleep apnea or simply excessive sleeping is often something people will have when they have dementia with Lewy bodies. They can also have other features of involvement of what's called the autonomic nervous system. So they may lose their sense of smell or have drops in their blood pressure, particularly with sudden position changes like standing up quickly. And this bottom right image is just to remind me of an interesting phenomena that some individuals with dementia with Lewy bodies will experience, and that is seeing meaning in sort of ambiguous stimuli. So many of you might look at that beverage and say, gosh, it looks like a face. And so our minds are kind of quick to create order out of disorder like that. But someone with Lewy bodies is more apt to do that, even with stimuli that ordinarily wouldn't be interpreted as a face or a recognizable image. So that phenomenon is called pareidolia, and they've done studies looking at how individuals with dementia with Lewy bodies are more apt to kind of see faces in unusual places, so to speak. So another aspect of the face of this type of dementia. You might say, well, gosh, you've been talking about dementia with Lewy bodies, but we also know that people who start with Parkinson's disease, with the classic tremor, walking changes, slower movements, they can develop dementia years later. Is that the same thing as dementia with Lewy bodies? Well, it turns out the scientific community has decided to use two similar but distinct terms to designate when an individual has Parkinsonism and dementia, the order in which those symptoms develop. So if someone has sort of a clearly established case of Parkinson's disease that is followed years later by dementia, it's termed a Parkinson's disease dementia. Whereas someone has the dementia first, or at the same time or within the first year that the Parkinson's symptoms develop, then it's called dementia with Lewy bodies. In the end, though, a pathologist looking at the brain of someone with either dementia with Lewy bodies who has Parkinsonian features, or someone who started with Parkinson's disease and later developed dementia, they're going to see the same thing. They're going to see Lewy bodies in the motor parts of the brain. They're going to see Lewy bodies in the thinking parts of the brain. The terminology just says sort of where did the symptoms start first? Did they start down deeper in the motor centers and then only later in the thinking parts? Or in dementia with Lewy bodies, you might think about the opposite order for the progression of symptoms. If you lump them together, we just call them the Lewy body dementia. So a little bit of confusing terminology, but certainly related conditions. All right, and then the final case is a 61-year-old woman, and she has a 3-year history of decreasing speech output, just simply doesn't say as much. She's no longer initiating a conversation, and sometimes when you talk to her, rather than answering a question, she just repeats back the question, what we call echolalia. She's developed some changes in her kind of personal preferences, a sweet tooth that she never had before, and she's gained some weight as a result. Some troubles with her judgment. She will either undercook or overcook food, doesn't seem to be able to recognize how long food should be cooked anymore, and has stopped doing certain things, lack of initiative in personal care and hygiene, where is wearing the same clothing days in a row. And when you examine her, her speech is very limited. She might just say a few words to answer a question, or sometimes she just says no. And it's not as though she stopped to think about the question. She might say that no, even before you finish the question. You might be asking her about other health conditions. Do you have any headaches? Do you have any numbness? And while you're saying, do you have any? She's saying no. So that impulsivity, despite her not saying very much, she's very quick to say things without listening to the full question. But she's not disoriented. She knows the date and location. But again, she has a lot of trouble just generating words. If you ask her to list as many animals as she can for a minute, she can only come up with 2. And she also has very concrete thinking. And when you ask her to draw a clock, draw the face of a clock, she literally draws a face with eyes and a smiley face, as might be shown here. So she's exhibiting some of the hallmark features of what we would call a frontotemporal dementia, which in and of itself isn't a single cause of dementia. It's really sort of a family of dementias that share the similar sites of pathology in the frontal and temporal lobes. So if dementia is the big umbrella, frontotemporal dementia is kind of a smaller umbrella, signifying a family of diseases with similar symptoms and sites of changes in the brain. It can happen at younger ages, and often is at a younger age of onset compared to Alzheimer's dementia. So onset before age 65 would not be unusual. And the early symptoms, rather than memory, are typically behavior and or language changes. And there can be physical symptoms that reflect problems with the front part of the brain. The front part of the brain hears kind of signals from the bowel and the bladder, so incontinence can occur early. You can also develop Parkinson's symptoms with some of these types of dementia. So Parkinson's doesn't exclusively signify a Lewy body dementia. And in some cases, you can get motor neuron disease or Lou Gehrig's ALS, so loss of muscle strength because of the deterioration of the nerves going to the muscles. That would be a classic feature of certain types of frontotemporal dementia. And there's a relatively stronger genetic component with frontotemporal dementia compared to even Alzheimer's dementia. Lewy body dementia has a relatively small genetic risk component. In terms of the classic symptoms of frontotemporal dementia, again, the hallmark features are often either a behavioral change or a change in language communication, so what's called an aphasia, or you can have combinations of those. So the behavioral subtype, people show a lot of changes in their sort of personal and social awareness. So their behaviors can be anything from being very disinhibited, sort of breaking social rules, not just eating at the supper table before anybody else, but then taking food off someone else's plate without asking, very compulsive or ritualistic behaviors, or very apathetic, just doesn't do anything, not initiative, not depressed, but just apathetic. In contrast, you can also have a very prominent language deficit, and there are two main types that occurs. One is called a non-fluent aphasia, which is just indicating the person can't really get those words out fluidly or fluently, so their speech is hesitant and effortful. Or you can see what's called a semantic dementia, where people literally lose the meaning of words. So it's not just that they have trouble thinking of a word, but even if you say the word, it's lost its meaning. So you might tell a person or ask a person with semantic dementia to pass the salt, and they say, salt, what's that? So they've lost that word meaning. And because these different symptoms, behavior, speech generation, understanding of words, involve different parts of the brain, sometimes the MRI scans in these cases will show very focal areas of atrophy or brain shrinkage. So in someone with behavioral symptoms, it's often very much towards the front of the brain. Someone with the semantic dementia, a temporal lobe, and can be very asymmetric. And someone who has trouble producing the words, it's also usually on one side in the front part of the brain. So looking for these patterns of atrophy can be helpful in making a diagnosis of frontotemporal dementia. Again, we don't have PET scans that can see the protein deposits that characterize these types of dementias, but there is a different type of PET scan that is sometimes used to distinguish an individual symptoms of Alzheimer's dementia compared to frontotemporal dementia, because the patterns of just general brain activity differ between these two disorders. So these PET images are not using any type of tracer that binds to plaques or tangles or Lewy bodies. These are scans using just glucose or sugar, the brain's main fuel, and seeing where sugar is being taken up in the brain. And so if you're just going to rest quietly in a room, you'll see a pretty uniform uptake of the sugar across the surface or cortex of the brain. And so that uptake would be signified by the brighter red orange colors. Someone with Alzheimer's, if this is the left half of the brain, this is the right half of the brain, so the front parts of the brain are facing each other, the back parts of the brain are here. Someone with Alzheimer's has a relatively characteristic pattern of reduced metabolic activity towards the back of the parietal lobes and temporal lobes. So again, where those tau deposits are typically occurring. Whereas someone with frontotemporal dementia, not surprisingly, is showing changes in the front part of the brain and also aspects of the temporal lobe. So this type of scan is in some cases covered by insurance, like Medicare will allow this type of PET scan specifically to try to distinguish someone with Alzheimer's dementia from frontotemporal dementia. And why is that distinction important? Well, as you'll see, the treatments will differ. And there are some treatments that are going to be uniform across the dementias, but we're really trying to develop more disease-specific treatments, because treating something related to plaques and tangles may need a different therapy than treating something related to the Lewy bodies, for example. And so there's a wide scope of dementia treatments, and it's not just for the dementia itself, but for example, in Lewy body diseases, there are treatments for the Parkinsons symptoms, for the sleep disturbances, et cetera. But I'm going to focus on just treatment of the dementia itself and specifically talk about what medications are currently used to try to halt the progression of the dementia in these various syndromes. And then Dr. Giordani will talk a little bit about non-pharmacological approaches. And I know there's another session in this month's series focusing on caregiver and caregiving issues. So what are the current medications that we use to treat the specific dementias? Well, I'm going to focus first on Alzheimer's dementia, because for the longest time, we've had two main types of medications to slow down the progression of Alzheimer's dementia based on trying to correct or compensate some of the neurochemical changes that are occurring in the brain. And here's a nice but complicated slide that illustrates how these neurochemical drugs work. So this is just a hypothetical series of nerve cells that are trying to communicate with one another. So nerve cell 1 is releasing a chemical called glutamate that's traveling across this gap or synapse to talk to nerve cell 2. Then there's different types of receptors that the glutamate can bind to, and then that creates a signal inside nerve cell 2. And then it releases a different chemical called acetylcholine that travels across and binds to nerve cell 3, and then it generates its signal. So that's the normal condition. Well, in Alzheimer's dementia, the nerve cells that make and release acetylcholine are often preferentially injured and disappear, or they lose their function and even die out. And so there's a loss of the acetylcholine there. So there's not as much of it to communicate to the next cell. So that signal has dropped down. It's not as high as here. In addition, in the setting of things like plaques and tangles, and the plaques are, I think, meant to be these little purple balls, there can just be an excess amount of glutamate. Now, glutamate's a normal neurochemical that we want to use for one nerve cell to talk to another, but when there's too much of it, it can just create too much noise here, so that there's too much background noise that when a normal release of glutamate occurs, you can't hear that signal through all the noise. So the two types of medicines to treat Alzheimer's dementia are designed to kind of correct those chemical changes. One type are what are called the cholinesterase inhibitors, because they prevent the breakdown of the acetylcholine over here. So they allow it to hang around longer, so that signal becomes higher again. And then the other drug blocks memantine blocks at the glutamate receptor to sort of dampen down the excess glutamate. So there's less background noise, so that signal can kind of reappear again. And if you use them in combination, in theory, you've got less background noise and higher strength signals kind of all across this process. So that's the theory, at least neurochemically, behind how these medications work. What does that actually mean for individuals with Alzheimer's dementia? What can we expect if we use these medications? Well, unfortunately, they don't cure the symptoms or reverse the symptoms. Typically, with these types of medications, compared to someone who's gradually declining from Alzheimer's dementia, if you add one of these medications, there can be a period of relative stability, or sometimes even a little bit bump up in function for a period of somewhere between 6 to 9 months. And unfortunately, there's decline after that, although the individual's still testing or functioning at a higher level than if they were never on the treatment. So it kind of keeps or delays that decline and continues to help them function at a higher level compared to not taking that treatment. What's the downside of any type of medication for Alzheimer's dementia? Well, the medications that tend to promote the higher levels of acetylcholine in the brain also end up promoting higher levels of acetylcholine in the rest of the body. And that's where you can develop side effects. There's a lot of acetylcholine in the gut. And so when we're enhancing that inadvertently, people can develop nausea or diarrhea. We also, acetylcholine is part of our dreaming state. So you can develop more vivid dreams, which can be good or bad, depending on if those are great dreams or nightmares. And there's acetylcholine in the junction between nerves and muscles. So people can develop muscle cramps, or the heart muscle can be slowed down. A slower heart rate can be a side effect. With memantine, the drug that works on glutamate, some relatively non-specific side effects, things like headaches or lightheadedness. But even when you first start it, sometimes people can have a little sort of tolerance difficulty and can transiently seem a little worse rather than maintaining their skills over time. So these are viewed as sort of symptomatic therapies. They don't really get at the hallmark plaques and tangles. They kind of act later on after the nerve cells are being injured and are making less of their neurochemicals. They help to try to compensate for those changes. So these drugs are used for Alzheimer's dementia. Here are the FDA approvals for these types of medications. They're used sort of across the spectrum for Alzheimer's dementia. The 3 cholinesterase inhibitors are. There have also been studies of the cholinesterase inhibitors in Parkinson's disease dementia, showing a similar degree of benefit, or in some cases, you might see a more robust initial response in someone with Parkinson's disease dementia because their cholinergic deficit is actually greater in many cases than in Alzheimer's dementia. So more broadly speaking, we'll use these in the Lewy body dementias as well. And again, there's different agents, but we consider them relatively equivalent. For memantine, the glutamate antagonist, it's really only been established in Alzheimer's dementia and only for more advanced, which is a little bit counterintuitive, but in the studies in mild Alzheimer's dementia, you really couldn't see a clear difference between taking that and a placebo. Now, importantly, you don't see vascular dementia on this slide. These medications really haven't had a robust effect in vascular dementia, although if it's mixed with Alzheimer's or Lewy body, we would consider these medications. You also don't see frontotemporal dementia on this slide. There isn't a disease-specific therapy for frontotemporal dementia. So there's a lot of work to go to improve our options for dementia treatment. But I want to just finish my session with just the newest drug development, and it's specifically for Alzheimer's dementia with a completely different type of medication. It's not working on the neurochemicals. This is a drug that's specifically targeting one of the hallmark pathologies of Alzheimer's disease, the amyloid plaques. And so this drug was approved just about a year ago. It's different. It's not a pill. It's an intravenous medication. It's called aducanumab. And we've known for a while that individuals who receive regular infusions of aducanumab who are experiencing early memory loss or dementia due to Alzheimer's disease, that if you look at the amyloid buildup in the brain using those PET scans again, that receiving a sufficient dose of the drug over a period of time can essentially remove the amyloid plaque from the brain. So here are PET scans from 4 representative individuals, all diagnosed with either mild Alzheimer's dementia or what's called mild cognitive impairment, sort of a pre-dementia stage. But in all cases, these symptoms were felt to be due to Alzheimer's changes because everyone had amyloid accumulation in the brain. And these individuals were randomized to receive different doses of the drug on essentially a monthly basis for a year. You can see if you got the placebo, the amyloid is still there, if not more, after a year. But as people receive different doses, those on the highest dose essentially had a PET scan that normalized at the end of the year. So we know these drugs are powerful, can bind to the amyloid, remove the amyloid from the brain, but there is a caveat that there can be side effects that are called ARIA. It stands for amyloid-related imaging abnormalities. These are radiologic changes of either bleeding or swelling that can occur during the amyloid removal process. And I'll say more about those in just a little bit. The big question has been, besides making a PET scan essentially normal, are these treatments of this type of therapy on balance helpful for someone with early symptoms of Alzheimer's dementia? And the honest answer is we don't entirely know, because the 2 large studies designed to look at the clinical benefit of receiving this type of drug and removing amyloid from the brain were halted at a partway point because they didn't anticipate they were going to see a benefit if they continued the studies. But in fact, when they analyzed all the data that they had up until the point that the studies were halted, the 2 trials designed to look at the clinical benefit showed somewhat different results. Those results are shown here. These are scores on something called a clinical dementia rating scale, where a higher numerical value means a greater level of impairment from the dementia. And this shows what happened if individuals received either the high dose, a lower dose, or the placebo. So in one study, those receiving the higher dose had less decline. So their rating scale was lower at the end of the trial. It was basically similar to what the placebo group was about 3 or 4 months earlier. So it seemed to be halting that decline by about 3 to 4 months. But in the other major trial, there wasn't a difference. So if anything, you could argue that the highest dose treatment group had a slightly higher, but clinically and statistically, those are really indistinguishable. And people will argue that these may be somewhat clinically indistinguishable as well. So we are left with this quandary that we know this drug has biological properties, but how helpful is it clinically? In the end, we have to balance it against the side effects, which in this particular trial, if you did receive that highest dose, 40% of individuals had signs of either or both types of ARIA, either swelling in the brain or bleeding in the brain. Often it was silent clinically, but you could have symptoms ranging from headaches to nausea and vomiting to particular difficulties depending on where that swelling or bleeding occurred. If it occurred in the visual centers of the brain, then you can have visual disturbances as well. So everyone had to be monitored very closely and carefully with MRI scans to look for these changes. And sometimes the drug had to be halted temporarily or permanently if these symptoms or radiologic changes developed. So in the end, the FDA, when they approved the drug last year, they did it on what's called an accelerated basis, which means it doesn't have to demonstrate clear-cut safety and effectiveness the way a typical approval would. The accelerated approval allows the drug to be approved based on its biological effect, which we clearly know it can do. It can reduce the amyloid plaques in the brain, but the evidence of clinical benefit can be to be determined. So an accelerated approval requires a post-approval study to confirm an anticipated clinical benefit. So there will be further studies of this agent, but we won't know anytime soon because the requirements for that confirmatory trial are that they be completed by 2029. Hopefully it will happen a lot sooner. But at this point, the drug is technically available for individuals with Alzheimer's disease at a mild cognitive impairment or mild dementia stage. But realistically, it isn't readily available because insurance typically is not covering it, or Medicare has at least issued a draft decision that they would cover it only in the context of a further clinical trial to really establish its clinical benefit. And many medical centers, including the University of Michigan, aren't offering it right now just because of this insufficient information about benefits outweighing the risk. So we definitely need more options for treatment. This may ultimately turn out to be an effective therapy, but again, we have to look at the risks and balance everything. And I think one of the challenges has been when looking at particularly these agents that target amyloid is that many of the studies are enrolling people with dementia symptoms or kind of pre-dementia, mild cognitive impairment. But when does the amyloid accumulation actually start in the brain? It actually starts many, many years earlier, before the onset of even the mildest symptoms. So it may be just challenging to have a robust benefit when you're trying to remove plaque that's been there a long time. So many of these agents are now being studied as prevention therapies, looking for those individuals who are cognitively normal, but silently showing buildup of the amyloid to see if removal of the amyloid at that stage can prevent the emergence of Alzheimer's symptoms. So several of those trials are underway. All right, and with that, I will switch back.
There we go. Great, Judy. Thank you so much. That was an amazing tour of the brain and all the issues that we see. So in the first slide is just a note that that really talks about an important feature of dementia that really you see between 70 to 90% of individuals with Alzheimer's, for example, eventually develop behavioral symptoms, including sleepiness, wandering, pacing, agitation, hallucinations, or even delusions. We know these things happen as the disease begins to march through various areas of the brain. So in the next slide, beside the issues of, if we can't solely depend on medications that might take a while to become effective or may only stabilize or slow the condition, there are certain specific reasons for non-pharmacological interventions, ones that don't include medication. One is the need to enhance an individual's quality of life and decrease these number and intensity of what we call behavioral and psychological symptoms of dementia, or BPSD. There's a lot of interest in how can we stop that issue. The goal is really to enable a person to continue to perform their usual activities of daily living, or with some changes, and to really address these symptoms of dementia that are often the biggest concerns with why people can't stay home. So the hope is really to address these symptoms, improve cognition, and hopefully help caregivers and allow people to stay at home for longer periods of time or stay active within an older age community. Next slide. So one of the set of things is called cognitive stimulation. So you'll see that a number of different centers or other people have available something in particular called reminiscent therapy, where you work with somebody to recall past events and memories, use pictures, different real aids. Some places actually put a camera around somebody's neck to take pictures of what happened during the day, and then you go over those with the person at the end of the day. It's a very interesting approach. There's work on what's called validation therapy to sort of validate to the person with dementia that they are a person and that the symptoms are not unexpected. There's reality orientation that tries to decrease some of the confusion and things people have by orienting the person to time and place and using a lot of information from current and personal information. There's also cognitive stimulation therapy, which really is considered including all of those above within sort of a guided textbook type of presentation. So people work through specific words, games, pictures of recent events. Now, the bottom line on most of this is that many of these have been shown to be actually effective in improving mood with persons of dementia, but there's really mixed results on sort of defining the cognitive benefits. There's a lot more sort of high quality evidence that's needed sort of across different places using these, because you may only have a few patients at Alzheimer's or dementia patients at one setting and a few dementia patients at the other. And also there's the issue of what type of treatment do you use for what person? Next slide. We do know that exercise and motor rehabilitation, when they're done safely and often, improves physical health and well-being and really reduces those behavioral symptoms. And you even see some enhancement in ADLs. So there's a lot of interest in also whether there is even changes in the brain seen following exercise. This sort of looks like, on the left, it looks like what my track kind of looks like at home because I'm really busy, and on the right looks like what happened when I try to get on the running track. But the other point is with this is that fewer than 5% of adults get that recommended daily amount of exercise of 30 minutes a day. So a number of these finger and pointer studies, they're called, across the world being sort of surveyed by the Alzheimer's Association, really all include an exercise component, getting out and walking more. Cognitive interventions. There are several types of cognitive interventions that have been developed. Cognitive training, for instance, that focuses on a particular cognitive function, like let's say attention or memory or executive, and then through a set of standardized, usually computer-based, but not always, they can be books, try and improve or maintain normal functioning. Cognitive rehabilitation also is more of a tailored approach, so that you really set realistic goals based on the individual patient and families with everyday life, like Dr. Hampstead looks at in particular in our group. This may improve patients' performance in trained tasks, but there's still no efficient, consistent event that if you train attention, does it really show up in other aspects of everyday functioning? There's a lot more research to be done, and rarely is this type of procedure used in dementia patients, because it may be really difficult to get a person in front of the computer and attending to what's going on, especially if they have spatial difficulties or other things. Next slide. Occupational therapy has really become an interest, in particular because it often involves exercise and things, but these are ways to try to train the patient to compensate for cognitive problems and help caregivers to cope with somebody's behavior, so that it's sort of a combined, there's activities of daily life, sort of like reminiscent therapy and things, and usually involves also skill training of motor skills. Several of these studies have actually been shown to be helpful to improve activities of daily living, because those are some of the things trained, but also these activities tend to have tend to have the result of people sort of lowering those psychological symptoms. And honestly, as those things occur, caregiver burden is reduced. And also because caregivers learn things they can do with a dementia patient that may be really helpful. Next slide. There is increasing interest in sort of alternative medicine or CAM sorts of approaches. Aromatherapy has, people are beginning to develop machines to let out different smells during the night to train your brain at night, or to train your brain to associate different types of smells. But there's also a lot of work in sort of looking at, do certain fragrances relieve health problems or improve quality of life? Does this calm the person? Often you have to sort of talk to your doctor about it, because certain types of different types of smell generating things can potentially, though, interfere with other medications and things. Music therapy is another one. Sort of using music and sound to sort of improve non-communication tools or induce change. If you see the gentleman at the bottom right, who, if you've seen that movie Alive Inside, he really just basically sat in a kind of vegetative state. And then when they play music that he loved when he was much younger in life, he really becomes alive. So there are a number of people really trying to apply music therapy in very fixed types of improvements and things. And there's much more research going on now with it, and using music with other types of skills like dancing and things like that. If any of you also saw the movies on Glenn Campbell, as he put out his last song, that was really a poignant song, given the fact that he was beginning to have dementia at the time, but you can see that he kept going on his concerts, even though he had many clinical signs of memory problems and other things. When he was up there, he could keep playing the music. Eventually, even using teleprompters didn't work anymore to give him the words, but he could still play the music. It's a very moving set of there's a YouTube set from CBS, and there's also the movie itself, both of which show different sides, from his wife's side, from his children's side, when they were up there playing with him. They're fascinating to show what music can do for somebody who knew music, that it was an important part of their lives. Art therapy, again, is another one. The sort of, can people maintain a preference that can maintain stable? My father was an artist his whole life, and even when he began having Parkinson's issues and motor issues, and then some decline in cognition, he continued to draw. His drawings changed as he had more spatial issues, but we have a number of those samples sort of following that over time. So art therapy is important. Some people use massage and touch therapy. Some centers are using that to sort of produce different physiological effects and hopefully change some of those behavioral symptoms. Next slide. There's a lot of interest also in sort of assisted devices and what they call domotics, household effects. You know, there's devices and sensors being put in people's clothing so we can monitor where they are if somebody tends to wander, or you could monitor medical symptoms or other things while you get that information about somebody's clothing. For falls in the hospital, for example, it's being used to show the initial signs of somebody's instability so a nurse can get there in time. More exciting than this really are what's happening with smart homes, where smart homes are really beginning to incorporate intelligent interfaces that really involve everyday objects, furniture, clothing, remind us to do things. You can have a mirror in your bathroom that basically reminds you the steps you need to go through, like brushing your teeth and so forth. There are more of these things beginning to be developed in places like University of Oregon and Boston and things that we'll see more of this going on. And it's important because, you know, if you think about it, nearly 3/4 of older adults with dementia are cared for in their homes. And we also know that there's a strong correlation between their home environment and disability-related outcomes. So what their home is like can often predict when they need to change. So these type of things are really important. Let me add on the next slide, something that one of the researchers in our center has done quite a bit of work in the past when she was with us, looking at canine-assisted therapy. This approach really involves animal-assisted therapy that defines an intervention in which the animal is really part of the intervention. The animals visit, for example, a nursing home with individuals with dementia. People naturally respond to animals, and this has really been seen to have a decline symptoms of dementia. I mean, this also now includes a whole series of robotic pets that you'll see. I've seen them in many of the centers appearing. This all started with the bottom left-hand side, which is a robot named Pero. And so for years, when Judy and I would go to the Alzheimer's International Conference, you know, way back when, I would see Pero, which in Japanese love baby seals. So this was developed in Japan to be responsive to individuals. And frankly, the first tries on this was it basically made very loud screaming sounds, which to me didn't seem relaxing at all. But now Pero has become a real robotic pet. You can pet the seal, you can talk to the seal. It responds much more like a natural animal would. And of course, in the US, there's now a lot of, I've seen several new grants looking at development of other types of robotic pets to resolve. But Pero will always be in my heart as the very first little robot for the house. Next slide. There's a lot of interest actually in virtual reality tasks and gaming, where people could wear headsets now and actually see the environment. And these headsets have improved dramatically. You probably see them on your grandson all the time, but they used to be sort of a very slow kind of perception in internal environment that didn't quite move right and things. But all of this work with new computers and things have made these environments really a 3D flow. It's just a you can see objects, you can see entities. You may not be able to touch them, but you can essentially mark them in things with your hands. Both physical and cognitive games seem to really have a positive improvement in mood and other things. One person may be initially startled by this, but people are beginning to use these approaches more and more. Next slide. So an example of how this was used by someone in our group was Dr. Davis up at Grand Valley in the nursing school, has really done a lot of work on using this kind of approach, but actually not even using goggles, but using a very large screen in front of the person that they could actually, you could take movies of their walkways at the senior center, senior living center, and actually help them develop the ways to move down the hallways better, to not get lost, to not wander as much. And now she's doing a lot of work actually on specific items in the hallways that can direct people towards their rooms. Because honestly, if you go to some senior centers, senior living centers, every wall is the same color. Now you'll see that's all kind of changing because people understand that people can begin to learn different motifs in each of those areas. And I really encourage people to use this more and more. Let me mention another thing on the next slide that's really expanding dramatically is approaches to telemedicine. Judy in your telephone. These are ways to provide assessment and care of patients at home, especially in rural communities, and especially because it's so hard for individuals to get to hospitals often. But if you have a real problem that's occurring and you don't know what's going on, this is a way to contact a physician immediately. Of course, all of this has blossomed in the land of COVID, but But actually, a benefit of this whole process with COVID has been just an explosion on how to use telemedicine for psychotherapy, for common medical concerns and things like that. And it also provides sort of in-home video monitoring. You can see the person. We have a video monitoring system in the School of Nursing that we use to send home with the patient for patients with heart failure, for example, who the system sort of provides the nurse, because nurses aren't covered for nursing care visits anymore after hospitalization. But now you can have the nurse can appear sort of on your iPad, and the nurse can not only test physical things, but somebody can come on and do cognitive testing, or can do cognitive and even physical exercises with you all through this little system you have at home. It's really pretty neat. And telemedicine appears to be really promising and effective, especially in the context of dementia assessment for patients at home, and especially in different countries like the USA, where we really have several rural retirement communities that are still medically underserved. I use a system similar to this in Africa, where we have certain spots where patients can go and connect to their hospital. These online training and support programs for caregivers of dementia too, they really look like they're yielding positive findings in terms of mental health outcomes, even marked cognitive. But the difficulty is that there really haven't been any large scale studies. And all of these things do things that on the face value look great for training, but nobody's really, we're hoping we're doing that, but nobody's looking specifically at specific cognitive skills to be trained and really how that works. So there's a flood of ideas out there, but nobody's really studied them individually. I want to also mention in the next slide the work that Dr. Hamstetter in our center is doing, looking at really exciting ways to look at what's called transcranial direct current stimulation, or TDCS. These are small electrodes or electrode pads that are placed in specific areas of the brain that can provide very low current, sort of like a 9-volt battery or 2 9-volt batteries worth of current. And this appears to excite areas of the brain that you may be able to do cognitive training during this, and this has been applied to patients with language disorders at our unit. It's been applied at the University of Michigan to people with motor concerns, Parkinsons, and other things. This is a very exciting approach. And one of the things that Dr. Hamstead is working on now is really working on a system that uses a patient's MRI scan, so a brain scan, to look at where specific areas of the brain are and determine the targets that somebody might need on an individual basis, that cognitive rehabilitation therapy. Look at things on an individual basis and provide a person with that kind of individual hardware you see in the middle, that individual headgear that somebody could use for training at home. And so now you can do home TDCS, and actually he's working on a program to deliver this across the state of Michigan. It's really an exciting area. It needs a lot more work. How much sort of current do you use? Where do you use the current? Do you use it high, low, alternating? All these things are things that Dr. Hamstead and his group is using. Next slide. I also want to sort of end with the use of therapeutic gardens, because research has shown that sort of a garden where somebody can move along, sit where they want, they can sort of wander on, really changes and increases freedom. There are a lot more of these gardens being used that sort of gently have somebody move within that area. They can't really get over the fence, but this has really been found to reduce agitation. Of course, we don't have all that time. I mean, I keep looking at my window here and it's snowing, and that's not an April Fool's joke. Every once in a while, I see a whole bunch of white stuff. But when it's available, Michigan is beautiful. And the gardens and you can have little waterfalls and things to interest people. This is a really important way to go, and seems to allow you to reduce those high doses of antipsychotics that are often used in dementia patients. And some areas are even building indoor gardens. Next slide. So I sort of want to end along that note to mention another thing done at our center, which is our Caregiver and Wellness Initiative, where they're looking at stress and resilience and well-being programs for family caregivers. So their monthly programs, their retreats, their courses, and all of these are using Bate gardens. Hope I pronounced that right. I'm always pronouncing that wrong, but the gardens at the University of Michigan for and the botanical gardens for doing different types of stress reduction and other techniques for patients and especially for caregivers. And this is really important work. Down there is Laura Rice-Osher, who's really I always have a picture of Laura because when I look at Laura, somehow I feel a little bit less stressed and relaxed because I kind of remember the things she's teaching and has taught me, and I sort of go automatically, ooh, this feels better. So last slide is if Judy and I are interested in answering any questions you have and things like that, and we'll be happy to do that. And we're all done. And Bruno finally finished on time for once, I hope.
Well, I anticipated with the topic and especially with these two particular speakers that this would be a terrific session with a lot of questions. And boy, was I right. This has just been great. Thank you so much. And we do have about 1.5 million questions. And just for the audience, I hope, saw that this session was scheduled to go until noon for 2 full hours because of that same anticipation of the topic and the questions. And so we do have a full half hour.
That this is also being recorded. Of course, it will be available.
Right, exactly. And that will be available or sent to the participants in about a week or so. And that's true for all these sessions for the Healthy Aging series. The first question I want to ask is about going back to the beginning of normal aging with its, declines, slow declines versus dementia. Is there a way to, forgetting a word versus putting the iron in the freezer, those are pretty, that's a pretty extreme. Is there something in between that would help people realize now's the time I should probably seek some advice?
Well, I can let Judy speak up here too, but in general, we're looking for things that are a change from what's usual. And that's those slow, gradual changes. But if you really notice them over and over again, or somebody in the family notices them, it's really a time to just, go in for a checkup. And frankly, I think checkups are great because you get a baseline so that you can compare future problems. But it's really, we know as we age, we have some changes. Mostly those changes are in motor speed. We don't hit that button when the light goes on. If we're doing a test of reaction time, physically we don't get there, but we can show that our brain says, whoa, it's there. So sometimes we just have changes. We know that our attention span as we get older sort of collapses a little bit like a fan, and we don't pay as much attention to things in the periphery. But these are very common and very minor. But when it changes, that becomes more of a significant event.
Yeah, I'll just echo that certainly anything that interferes with daily activities, we would say, please come in and get evaluated. But it's really the sort of persistence and the magnitude of the symptoms that lead us to the next step. So as Bruno gave some of those examples, but it's not just, do I remember that actor's name in the movie I saw, but did I forget that I went to a movie yesterday? So it's kind of a qualitatively different magnitude. And by definition, for it to be dementia, it needs to impair daily activities, but there is that pre-dementia state, mild cognitive impairment, which may deserve further attention too. And that's really defined as having a clear change, testing below expectation for your age and background, but still independent in daily activities. So that really does need a clear cognitive assessment. And the nice thing is if people do have regular wellness checks through their annual wellness exam, then sometimes that change can be picked up that way too.
I think that Judy's absolutely right. I think Judy knew my mother well, and my mother really could talk and sound great, but in the end was not really acting great. And even she had been an attorney and she kept meticulous records for all of her taxes. But we realized when we went back and looked even 5 or 10 years earlier, that beautiful handwriting was beginning to go down the end of the page, was beginning to, and we didn't even see those things initially. Actually, we saw my mother had problems when one of the times when I opened the kitchen cabinet and there was all this ragu tomato sauce, because she'd forgotten the order of how to make her own tomato sauce. So her correction was to use ragu and sort of add a bunch of stuff to it. And so that was her compensation. And really, my father didn't notice things till I kind of opened the cabinet and said, wow, there's a lot of bottles of ragu in here. So you just don't know.
Judy, I had mixed emotions when you said that snatching food off somebody else's plate might be a problem.
Doesn't count McDonald's French fries from your spouse. That's
Oh,
an
yeah,
exception.
okay.
So, you know.
Thank you very much. All right. I have seen multiple lay press type citations that 1/3 of people over 85 have dementia, Alzheimer's. I'm not sure they specify. But then, Bruno, early on, your slide had the prevalence at 85 at about 17% ballpark. But then you also mentioned that 85 it was 40%. Is it beyond 85
there's
plus?
Prevalence and risk are two different things.
Right.
You know, and that's part of it, you know.
And I think that slide also was from Europe, and the exact prevalence will vary. Well, I mean, it's certainly age-dependent risk is there everywhere you look, but the exact numbers will vary. Places that follow a more Western diet, it may be higher than what that European slide showed. So, yeah.
You know, one of the things that's been shown now actually by Ken Langa, one of the allied investigators to our center, is that there's actually in Western countries, there's now been sort of a surprising decline in the appearance of dementia. But if you think about it, we're all being told to eat properly, to exercise, to stay active, all those things you're supposed to do, and it may actually be having an effect. Whereas in other countries, many of the countries in Africa, it's actually increasing quite a bit as frankly, people adopt our way of doing things more. And that's been, you know, when I visit, I have some research sites in Africa, and one of the sites I visit, and the time I visit is always exciting because, okay, he's going to take us to a restaurant and everybody orders fried chicken and fries, you know, and as much as I like those, I begin to think, boy, if you're doing this all the time, you know, no wonder there's sort of an uptick.
And I know when Ken Langel tried to look at what factors might be responsible for that reduced age-specific prevalence over time, the thing that stood out actually was higher levels of education in the more recent cohorts. So that stay in school early on, build up that cognitive reserve, suggested to be a potential reason for that.
Come to hear us talk. There's an education.
That's right.
Right. It was interesting to see, I think fascinating, that the single biggest factor people can deal with is hearing loss. Is it the case that people who are deaf congenitally therefore have a higher incidence of dementia eventually, or is the plasticity of the brain able to deal with that?
Well, that's a good question. I don't think people have that understanding. I'll tell you what, when that came out about 2 years ago, I think, or whatever, 3 years ago, I forget time within the COVID barrier, but there was a big surprise because this was very carefully done across all the studies going on in Europe, that they really looked at this and found hearing to be important, and everybody got surprised. So people are looking at congenital hearing loss. In some of our research that we're doing, it looks like it really, so we're looking at cochlear implants that can be used with many people across the ages. And for us, we see differences based on when the person first lost their hearing. So it also may be early education. Like I said, it could also be that social way, but those studies they just haven't been done yet. But I can tell you they're being done because of all that popped interest, because it superseded some of the expectation with genetic factors. So it's a complicated interaction, but people are looking at that.
Back to the early onset versus, not early, I mean the earlier signs versus just normal aging. Do those physical signs or symptoms, do they differ from the early stages of dementia versus just what happens to all of us eventually?
I'm sorry, do you mean the early signs of motor problems?
Yeah, when people have, I don't mean early onset Alzheimer's, I mean the early stages of Alzheimer's in an 80-year-old. Is it just the rapidity of how those changes happen compared with somebody who is just aging and the forgetfulness and a few other things here and there?
Well,
Yeah, I mean,
let Judy.
yeah, I mean, for each of these dementia causes, the early symptoms can vary, but for example, the normal changes with aging, maybe it just takes longer to get to that word, or it takes longer to bring up that memory, or it's harder to multitask, but people can still do it if given sufficient time. Whereas in early Alzheimer's, prompts may start to fail. And so there's, again, a little bit of a qualitative difference in performance is different. And the nice thing about detailed neuropsychological testing is we can compare you against the expected score for your age. And so if you're aging normally, even if you're not as fast as you were 20 years ago, you're still maintaining your place in line, so to speak. And so putting things in a age-adjusted context can be very helpful to try to decide, is this beyond normal aging?
Yeah. But you'll
so
see
in rehab,
different
we all
signs.
talk about function, level of function. And so that sounds like that's what you're
Mhm.
talking about. Maybe forgetting a word, but it doesn't affect your function day by day, but then that becomes the issue.
Yeah.
Okay. How about with brain imaging? Would somebody, you know, I always think back, I forget how long ago now, Daniel Shore, the commentator on NPR, who was like, I think 92 or 93 when he passed, but until the day he did die, he was just, you know, as sharp as could be, his commentary. Would his brain MRI have looked different than not somebody with dementia, but somebody who was just 92 and maybe not quite that sharp and forgetting the few words here and there?
Yeah, that's a great question. And, you know, so-called super agers who really, you know, have fabulous memories, you know, up into their 90s are an area of interest now at certain places like Northwestern, but probably people are not getting MRIs if there's no impairment or reason to. So we don't have a lot of data to answer that question at this point, but that's an area of interest.
We are, you know, we're part of the interest in Northwestern. We are starting along with that group now to look at superagers. So one of our junior faculty, Amanda Maher, has a study with Northwestern where she's going to be looking for individuals over 80 who are doing very well sort of across this whole area, really interested in looking at imaging changes and looking at cognitive changes and sort of what we call superagers, people who don't have cognitive problems yet they're in their 80s or above.
Okay. So-called early onset dementia is, I assume that's not, the question is it just Alzheimer's? Could it be Lewy body? I'm assuming that vascular, depending on the cause of the vascular issues, could also lead to that. But what about that? Is that typically Alzheimer's eventually?
Yeah, so if you shift and focus on folks before age 60, Alzheimer's can still occur. It makes us think more strongly about genetic causes. So if someone has a family history where they and people across multiple generations have developed dementia before age 60, then it could be one of those rare cases where there's an underlying mutation in one of the genes that ends up changing amyloid production as a cause. But frontotemporal dementia typically starts at younger ages. So dementia before age 60, frontotemporal dementia and Alzheimer's start to become sort of similar likelihood just based on numbers. And certainly, as you said, if someone has risk factors for vascular dementia that begin at an young age, maybe some sort of congenital heart disease that predispose them to cardiovascular events, things like that, that could be under consideration too.
The early onset that we're talking about, of course, is a very small, like Judy says, a very small group of individuals. It's interesting that it's expected to be about 200,000 individuals, but now there was some research reported last year that suggests it could be a bigger group than that have early onset. But there's just so much more research to do, but they look like other patients who have older patients who develop Alzheimer's. You see the same changes of plaques and tangles, but a much earlier age.
And are there any detectable genetic markers?
Yes, so there are three main genes that contain a variety of possible mutations that are linked to familial early onset Alzheimer's disease. So an individual could be tested to see if they carry a causal mutation, if they have that family history and early age of onset. I guess I just would add the other very young onset Alzheimer's disease would be an individual with Down syndrome, because they, with trisomy 21, have an extra copy of the gene that carries the amyloid protein in it. So they overproduce amyloid by virtue of having that extra genetic material. So they have a very high likelihood of Alzheimer's dementia, by their 40s or 50s.
And if I send the sample away to, what's it called, 23andMe or whatever it is, would those markers show up there?
So they don't typically do the genetic mutation testing. That's usually not advised. And like someone who wants to know, is it running in my family, but they don't have symptoms? Typically genetic counseling is advised before that. They will test for the genetic risk factor. It's not a mutation, it's just a normal variation in the apolipoprotein E gene. There are three types of that gene, type 2, type 3, type 4. As with all genes, you get two copies. They can be the same type, they can be differing types, but having one or more copies of the E4 type increases your lifetime risk of developing Alzheimer's disease. So 23andMe does do that. They initially did it, got put on hold for a while. There were concerns that people were given those results without necessarily saying, hey, I wanted to know about my Alzheimer's risk. But I think it's back in the panel that they can choose now.
Someone asked about their own family history with a mother and a sister with early onset Lewy body. And the father also happened to have Parkinson's. Mm-hmm. And the woman who wrote this the person who wrote this and her sister are both in their early 60s now. Anything about that with Lewy body?
So not typically nearly as commonly running in families compared to, frontotemporal dementia probably the highest, then Alzheimer's. Vascular, it's more the vascular risk factors run in the family. But there are cases of familial Lewy body diseases. So there can be alpha-synuclein gene mutations, for example, and others as well. So not unheard of to have a familial Lewy body disease.
Okay. Now, granted, it's been about 45 years since my neurology rotation. Somebody's asking about the correlation between migraines and dementia. And my memory is that migraine, the word comes from hemicranium, half the brain. And so that it would seem that would not be a true migraine. It seemed that wouldn't be correlated because Alzheimer's is a diffuse, or dementia is a diffuse process, but educate me.
Yeah, I don't think of migraine as a risk factor for Alzheimer's dementia. I mean, there may be rare migraine syndromes that are linked to vascular events, but again, not something we typically consider as a risk factor for dementia broadly.
Okay, all right. Someone wants to know if Lewy body and Alzheimer's can coexist. And also has the question of, if they do, is the Lewy body pinpointed by the symptom of people seeing faces in unusual places or in weird settings?
So that's a great question. And the answer is yes. It's unfortunately very common to have mixed pathologies, and particularly combinations of Lewy bodies and amyloid plaques, not necessarily the tangle. So someone might not meet the full pathologic definition of Alzheimer's disease plus Lewy body disease. They might have Lewy body pathology plus amyloid pathology. So it's estimated about 75% of people with dementia with Lewy bodies also have some degree of amyloid plaque deposition. So an amyloid scan, if you could get an amyloid PET scan, wouldn't rule out the possibility of Lewy body. If they had amyloid accumulation, they could have those two together. So the reason, we think more about the presence of the Lewy bodies based on a little bit of that cognitive profile. But if they've got a mixture, sometimes they can have a prominent memory loss as part of their overall syndrome. But it is some of those non-cognitive symptoms, the Parkinson's, the sleep, the dream enactment is it really sort of shifts your thinking towards Lewy body as a potential cause, because that just has a high correlation there. That's not to say everybody who acts out their dreams is, going to develop a Lewy body process, but it definitely is a identified risk factor. But again, the prominence of the hallucinations, if they occur very vividly early on, compared to someone who has pure Alzheimer's dementia, those hallucinations might be milder, infrequent, or later on in the course. So hallucinations in the first year of the dementia symptoms or sometimes preceding the dementia symptoms, to me would raise my suspicion for the Lewy body.
I should also add that one of the goals of our center is really to study the non-amyloid dementia. So not just to emphasize AD, but look at all the other causes. So we do research in Detroit looking at vascular issues and things with a higher risk among African Americans. We have a whole Lewy body group. We provide group services and talks every year. We have a Lewy body disease center meeting. So that's also of real interest to our center. Again, these non-amyloid, non-pure AD, how do these things interact is a big question at our center.
Someone asked, is there any role of estrogen or lack of estrogen eventually on, or other hormones on dementia?
That's a great question. And obviously with women being at higher risk for Alzheimer's dementia, that certainly comes to mind. Is it because of that postmenopausal loss of estrogen? Epidemiologic studies had suggested that women who take hormone replacement therapy had a lower risk of Alzheimer's dementia. But then the Women's Health Initiative studied postmenopausal hormone replacement, and lo and behold, those who received the hormone replacement had a higher risk of developing cognitive symptoms. Now, they were treated, I think, many years postmenopausally, not right at the time of menopause. And so there's been some more recent studies suggesting maybe if you use the hormone supplementation early on, it may be protective, but later on it may be detrimental. So we don't know exactly is the bottom line, but it's certainly a consideration as to why women may be at higher risk.
I mean, we know that women have that higher risk, even regardless of just the fact that they're aging. This has become a real interest in research over maybe the past 3 or 4, maybe in 2 or 3 years, especially, as to why is there this difference. The Alzheimer's Association has pushed that really hard, as well as NIA, to National Institute of Aging, to really understand why. They've even seen some differences in the way amyloid deposits in the brain. That women may have more of a typical pattern than men, or it's a different distribution. A lot of interest in the interaction with vascular issues. They've even done some work looking at number of children you have, jobs you're doing. There's all sorts of really interesting work, but it's just coming out, so it's hard to say anything definitive about it.
Someone asked whether people with in the early stages of dementia, are they aware of their mental decline, or at what stage? I think, Bruno, you kind of alluded to this with Glenn Campbell a little bit.
Yeah.
But any further comments on that?
Well, I mean, for example, my mother really honestly had no recognition of her dementia for the longest time. And for her, one of the things that happened was she called the police one day and said, my daughter was writing checks and stealing money from her. And of course, they had this incredibly close relationship to this. So the police came, and my father was pretty upset. And the police actually noticed fairly quickly that my mother was not quite making sense. But before that time, she was denying any problems. And my father was upset. And what we actually did was, when we opened the back of her checkbook, it was full of torn checks. And she said, see, Helen is trying to do this. She's practicing it. Really, it was my mother that would write the check, would realize it's wrong and tear it up and put it away. But when we put out all of her checkbooks, because she kept every checkbook back to like 1956, she looked and saw that all that handwriting was just the same as those torn up checks. And she sat down and said, well, then this means there's something wrong with me. But that was probably the first time that she ever really accepted that issue. I mean, my mother's famous for sitting at dinners with all sorts of famous people who would tell me how great they are, whereas Judy and I knew she was moderately demented, but she sounded great. But that was probably the first time that she really accepted that she needed to be more careful, and was willing to leave the house, go with my father and live in an independent community.
Yeah, so the dementia itself can take away someone's ability to recognize their thinking changes. And so there used to be kind of an old saying that if the patient isn't concerned, but the family is, they probably have dementia. If the patient's concerned, the family isn't, they probably don't. But it's, that's an oversimplification. There are certainly people who are aware of when their cognition is changing, and they may be coming in on their own, not because others around them have pointed it out. So it can really vary from person to person. Now, if someone comes in and they're concerned and they can tell you exactly every time they had a memory lapse and what the details of the memory lapse were, they really have pretty good memory about their memory lapses. So we're less concerned in that situation. But again, that awareness can really vary even within a given disease. So it isn't something where everybody with Alzheimer's is unaware and everybody with vascular is. It can really vary just within the person.
Okay. Are there any tests or treatments specific to Lewy body dementia?
So Lewy body dementias, again, have a variety of features besides the cognition. So for the cognition itself, the treatments would typically involve the cholinesterase inhibitors because there is a cholinergic deficit with Lewy body dementia. The glutamate medication, memantine, has been studied on a limited basis in Lewy body and sort of hit or miss. Some people seem to benefit, some people it seems to aggravate some of their hallucinations or other features. So it's kind of on an individual basis. Beyond that, there are medications that might be used for the Parkinson's symptoms. Again, that can be a little hit or miss. Sometimes they respond very nicely. Sometimes there isn't a response. There are medicines for the dream enactment. So again, individual symptoms can have treatments. As far as a specific test, again, we don't have that biomarker to confirm. If you happen to do that glucose PET scan that I showed pictures of, where with frontal dementia, it's the frontal hemispheres, and Alzheimer's, it's more posteriorly. If you did a glucose PET scan in someone with a Lewy body dementia, the pattern would look pretty similar to Alzheimer's, but additionally, you might have farther back, more posterior occipital hypometabolism, which is interesting because they have a lot of visual disturbances. So again, that's one hallmark feature, and you might have a little less of what's called the posterior cingulate involvement. So the pattern can be a little different, but it's certainly not absolutely diagnostic at this point.
Someone asks if there are blood tests regarding blood tests, for dementia. Is it possible that kind of like cholesterol screening that could be used to do some preventive measures? Is there anything on the horizon for that?
At this point, the only commercially available blood test is designed for people with cognitive impairment where Alzheimer's disease is a consideration, because that's the population that it was tested in. And it's looking specifically at types of amyloid protein in the bloodstream. It also does an ApoE assessment as part of it and combines that with age and yields something called an amyloid probability score, because it was compared against amyloid PET scans. And so a high score would suggest there's a high likelihood if a PET scan were done, you've got amyloid. A low score would suggest a low likelihood. And then a certain percentage come back and determine it where you can't make a good prediction. They sort of set the cut points in the population that they tested this in, so that the accuracy of either a high or a low score would be around 85%. So that means there's still a 15%, you tell someone low chance of amyloid in the brain, 15% of the time it was different. So now the theory, in theory, because these amyloid markers in particular change before symptoms develop, that test could be used in an at-risk population. It hasn't been sort of released for that, and it would have to be with sufficient caveats, because simply having an amyloid change, even on a PET scan with someone with normal cognition, we don't know what the sort of lifetime risk of dementia symptoms is with that amyloid PET scan, let alone a blood biomarker. But in theory, that's the way things could head, that you could develop a risk profile from a blood biomarker.
I mean, that's the hope of the future sort of thing, but also that these blood biomarkers could be used as ways to know maybe who needs that PET scan or who might need that extra care. We have in our center, we have a number of cores or main units, like an imaging core, a clinical core, so forth. And we also now, sort of mandated by the the centers, by the national centers, is we have a biomarker core. It's a very large core that's really looking at all these different potential blood-based biomarkers, even helping us with that research in Africa. So it's really quite amazing. I shudder a little bit because they're at Michigan State, but you know.
And I'll just add that there is a blood biomarker being now introduced in a clinical prevention trial, because initially just screening people cognitively normal with PET imaging was, low yield, that we were finding elevated amyloid to enroll in the treatment phase of the trial. So now people are getting pre-screened with a blood test and using that to decide, do they at least have some likelihood that the amyloid PET scan is likely to be positive, so that we don't have a 90% or so, negative rate when we do the amyloid PET scan. So those tests are being used in clinically normal people in research at this point.
Is there any evidence basis about sleep habits related to development of dementia?
Well, I mean, there's more and more increase at this center research as well, wondering about whether sleep changes could be indicative. I mean, Judy talked about the sleep changes that you can have with certain diseases. Is it possible? One of our postdoctoral fellows in nursing looked at whether changes in sleep could be associated with changes in memory. We know that the brain, certain biochemicals, cortisol and other things, have alternations that occur with everybody while they sleep. Is it possible that individuals with sleep disorders aren't having that same appropriate change? And maybe that could be an early marker.
And I believe you're going to have a further topic on this this month.
Oh, but good. So I didn't say anything.
There's increasing evidence. I mean, these proteins that accumulate in Alzheimer's disease are proteins that we all normally have in our brain. They just are hopefully not developing the form that aggregates in these plaques and tangles. But there's evidence that the normal sort of circulation or clearance of these proteins can happen more in the restorative deeper stages of sleep. So someone with insufficient hours of sleep or disrupted sleep, like from sleep apnea, potentially could be at risk of the amyloid buildup, for example. And there have been a few scary just press releases like missing one night of sleep increases your brain amyloid X%, which means all of us are in trouble. But again, my hope is your brain catches up the next night, but it's an area of very interesting research.
There have been some studies looking both at individuals with memory problems that aren't Alzheimer's, but aren't yet Alzheimer's, people looking at mild cognitive impairment patients and suggesting that disruption in sleep really does lead to some increased accumulation of amyloid in the brain. So we don't know the answer yet.
A lot of unknowns still. That session is 2 weeks from today, and the last April session is 3 weeks from today. That's the caregiver session. Well, you guys, we're just past noon. I want to thank you so much for this. There were many more questions I could not get to. It's just we have well over 300 people currently at the peak, and so there were just dozens of questions. Thank you so much. This has been terrific.
If you look for it, the Alzheimer's Association can often answer those questions, or our center. If you look us up on the web, you can find our address, learn about our different research projects, get some questions answered.
Great. And once again, the video of this will be distributed to all participants in about a week or so.
Okay.
Thanks again. Take care.
Bye, everybody. Bye.